So a lot of people think that advanced care planning is a piece of paper, that it's a document, what we call a healthcare directive, and that if you have that piece of paper done, you're done with advanced care planning. That's not really true. Advanced care planning is really a process. It's really about conversations. It's really about, like I said earlier, thinking and talking about what types of things you would want done if you couldn't speak for yourself. And things change through our lives, and so this isn't a one-time thing. You keep working on it, you keep going back, you keep talking about it. A lot of people say, oh, well, I'm young, I don't need that, or I'm healthy, I'll do it later. But the reality is none of us know. Any one of us could have a car accident, a sudden illness could come upon us. Things can change very, very quickly, and so it's really important that every adult at least start to think about this, because there are no guarantees in life. And the fact is, if you end up in a hospital bed and you're not able to talk, and you've never shared any of your thoughts or feelings about this with your family or your doctors, they have to guess. They don't know what you would want if you've never shared that with them. There's a lot of information about this topic right now online, and at most hospitals and clinics in Minnesota, you can now get information. And then there's groups like us, Honoring Choices. We come out, we do talks, we do teaching, we will make appointments to sit down with people one-on-one. We're here to do whatever needs to be done to help get this message out. There's been some national research on this topic, and a question was asked, is this an important thing to talk about with your loved ones? And you can see 90% of people who answered the survey said, yeah, this is important, I should talk about this. And then we said, have you done it? Only 27% have actually talked about it. So then we took to the next question was, well, if you talk about it, should you write it down? So we have a record of this. And again, most people said, yeah, that's a good idea. And in Minnesota, 35% of us have done this. Now nationally, the average is about 27%. So we're above average in Minnesota, but we still have a long way to go. And then finally, the third step, we asked people, after you've talked with your family, after you've written it down, do you think you should share this information with your doctor or whoever your primary healthcare provider is? Again, most people said yes, but if you look at how many people actually have done that, it's really low. Only 7% have talked about this with their caregivers. That's where you guys come in. You guys could be, from what I understand about your role as community health workers, is you can be an excellent way to help people understand what this topic is and help be the bridge between their thoughts and their conversations and the healthcare community. So Honoring Choices, like I said, we began because we looked at these types of numbers and we knew we wanted to change things. We wanted to make it better. Now when you think about why don't people do this? Well, one of the big reasons is fear. For a lot of people, thinking and talking about dying or end of life or even a very serious illness situation is very scary, and a lot of people just don't want to even go there. And we know that. And that's true for doctors too. Doctors don't want to think about their patients dying. Some doctors view that as failure. And even if they don't, most doctors were not taught in medical school how to have these kinds of conversations. So it's fear on both sides. There is also an element of, if you talk about it, are you attracting it into your life? If I talk about end of life, if I talk about dying, is that going to somehow make it more likely that it's going to happen? Or there's a fear, maybe you're fine with talking about it, but you want to talk about it with your family and you're worried about their reactions. We've heard people say, well, if I talk about this with my parents, they're going to think that I just want them gone. And I don't want them to think that. And then finally, there's a real fear we know. A lot of people don't trust the health system. And again, this is where you guys can be so important to this work, because you have the ability to meet them where they're at and help waylay some of those fears. We also know that oftentimes beliefs and traditions prevent people from entering into these conversations. Maybe in the culture that you are from or the family traditions you have, you just don't talk about this. It's almost a taboo. Some people say this isn't for us to decide. This needs to come from our faith leaders. We need our spiritual leaders to tell us what to do. This isn't for us. And related to that is we don't need to write things down. God will decide, or whoever the spiritual being is. But finally, what we found really the number one reason people don't talk about this is because they just don't know how. You can get past a lot of those fears, a lot of those beliefs that are blocking conversations if you can provide information to people about what this is and, just as importantly, what it's not. So we know, and this again with healthcare workers would like to talk about this with their patients, but they don't know how either. Honoring Choices teaches them too. We're not just teaching people in the community. Sometimes having something in writing helps, or a video that you can watch helps. And we have a video, I believe WellShare should have some of this, but I can also get you copies, that explains what advanced care planning is in Hmong and Somali and Spanish. And when we had these videos made, we didn't tell the people what to say. We said, we found people who understand advanced care planning, and we said, you make the video in a way that will be appropriate for your culture. So the 3 videos are very different based on the cultural background and traditions. So talking about advanced care planning, we know it's not an easy thing, but it is easier than you think, and we really can help. So I'm going to explain a little bit more about what advanced care planning really is. It really comes down to 3 questions. The first question is the most important one, and that is choosing the person that you would want to make decisions for you if you couldn't be involved and make those decisions yourself. So a lot of people choose their spouse, or maybe their oldest adult child if they have children that old, or maybe a sister or a brother. It's not always, the first person you think of isn't always the best person, and we'll talk about that in a minute. So the first question is, who's going to be your voice if your voice can't be heard? The second question is, if you were in a medical situation where the healthcare team all agree that you're not going to regain the ability to know who you are, where you are, what's happening, what would you want to happen then? There's no right or wrong. It's just a good idea to talk about it. Some people say, I want to be kept alive. Even if I can't interact, please use the technology that's available to keep me alive. Other people say, if I am not going to regain my ability to know who I am, my ability to interact, my ability to understand what's happening, then no, it's okay to allow me to die. There's no right or wrong, but helping your family understand which you prefer is going to make it easier for them if they're called upon to make these decisions. And then the third question we ask people to consider are, what's important to you personally? What are your beliefs? What are your personal values and goals? What does your culture say about this? Writing this all down and talking about it ahead of time gives a guideline for your healthcare team so that they know what's important to you. So remember I said a lot of times people choose their spouse or their oldest child or maybe a sister to be their agent. There's really 5 things that we ask you to consider. The first one obviously is, do you trust this person? This person has to know you, and you have to be able to rely on them. And some of the decisions they have to make may be pretty hard. So it needs to be somebody who you can count on to be level-headed. Question number 2 is a really important one, because sometimes what you want and what, let's say, your husband wants are different. Is he or whoever you call on to be your agent, your spokesperson, are they going to go with what you want? Or are they maybe going to try to trade your choices for their own? You need to think about that ahead of time. And then number 3, you think about the decision that she just shared, where they were, their mother was very, very ill. It was a very emotional, stressful time. Sometimes people who are part of the family, who are very, very close, simply want to be able to sit with their loved one, hold their hand, be a family member. They might not want to step aside and make decisions. So sometimes it can be helpful to have somebody maybe one step removed, maybe a cousin or a sister-in-law or somebody who knows you well but maybe has the emotional distance. Sometimes though, your spouse is the one who wants to do it all. You just need to find out ahead of time. Number 4 is a big one. We know that oftentimes if somebody is laying in a hospital bed and they're not able to communicate, you could have 4 or 5 family members standing around the bed, all disagreeing. One of them is saying, she's had a good life, it's her time. One of them is saying, I am not ready to let go. One of them is saying, well, let's just give her 3 more days. You can have a lot of disagreement. Your agent, the person you pick, needs to be able to say, right here in her directive, this is what she said and this is what we're going to do. They need to be able to be strong enough to stand up to family members who are disagreeing. And then finally, the last consideration is just a practical one. Is this person going to be available if there was an emergency? Now, in this day and age, available can mean by phone or by Skype or FaceTime. It doesn't necessarily have to mean somebody living next door, but are we going to be able to reach them and involve them? Now, the second question we talked about, remember, was about if you're in a situation where the doctors are agreeing that you probably aren't going to be able to recover. We, on the directives that we recommend, we don't list a lot of treatment options. Like, yes, I would want surgery. No, I would not want blood transfusions. No, I would not want dialysis. Because you don't know what is going to be useful or helpful. Because you don't know what the situation is going to be. If you complete your healthcare directive, you write all this down and you start talking about it now, I mean, all of you right here and now, you all look pretty young and pretty healthy. It may be 30 years before anybody needs to use this. And if you write down things based on today's technology, it may not make any sense 30 years from now. So we don't talk about specific treatment options. Instead, we talk about goals. What are the goals? Sometimes, if you haven't reached that point where you're not going to recover at all, maybe you're unconscious now, but there is still a possibility, a strong possibility that you will regain consciousness and regain some activity. But because you're unconscious now, other people are making the decisions for you. Well, if sometimes people have a goal like, my granddaughter is getting married in May and I want to be at that wedding. And so then your agent can talk with your doctors, and when the doctor says we could do surgery, we could do antibiotics, we could do other therapy, you can say, well, we know she wants to be alert and strong to go to this wedding. Is that going to help us meet that goal? If it is, let's do it, because we know that's important to her. Sometimes people are in a hospital and their wish is to die at home. They don't want to be in a hospital. They want to be home in their own environment with their family around them. So then again, you look at the treatment options and you say, okay, what can we do to facilitate a move to the home for the final days of life? And that's how you make your decisions. So it's not about which medicines you're using. It's not about what therapies you're using. It's about what is going to achieve your goals. And to understand what your goals are, we have a couple of questions that we ask people. We ask them to think about what gives your life meaning. A lot of people will say, seeing my children grow, or maybe listening to music, or being at church, or visiting my cabin. You know, a lot of people will say things like that. And so you think about what is it that's important that you would like to be able to preserve. And if being around your family is the most important thing to you, then maybe that's going to guide where you get your healthcare treatment. Maybe your options are you could stay here in a local hospital, or you could be transferred to the Mayo Hospital in Rochester. Well, if the number one thing that is important to you is having your family nearby, you probably aren't going to want to go to Rochester. You're probably going to want to stay here. So again, knowing that information ahead of time makes it so much easier for your family to make these decisions. We also ask people to think about, what are they afraid of? You remember at the beginning we talked about fears. And lots of times people, if you talk with them, they'll share some very specific fears. One fear we hear a lot is that this is going to bankrupt my family, that my end-of-life health care is going to make my family lose all its money. Now, advanced care planning can't remove that fear, but if you can get people talking about it ahead of time, you can maybe help them find some resources to do some planning and to figure out what they need to do to prevent bankruptcy from happening. But sometimes the fears are relatively simple. I had one woman tell me that one of her fears is she was afraid she was going to be laying in a hospital bed and people would be coming to see her and her hair would be a mess. Her fear was that people would see her looking messy. Now, I told her that's a wonderful thing to write down, because then her family knows. They can come in the morning, they can comb her hair, straighten her sheets, make sure her face is clean. It's just a little thing, but they know it matters to her, and they can feel good because this is a way of expressing their love. And then finally, we ask people to really think about, what do you do now to get through stressful situations? Again, you'll hear a lot of the same answers. You'll hear a lot of prayer, listening to music, being with my family. For some people, it's having time alone. It's whatever helps. Some people want to get a massage. Some people want to be outside. It's whatever helps you, because if we know that now, your healthcare team can try to provide that for you later. I had one woman in a class that I taught a couple weeks ago. She said, I don't care what condition I am in. If it's humanly possible, take me outside every single day. She says, and she lives in northern Minnesota. She said, I don't care if it's 30 below and I'm completely unaware of what's going on. My skin needs to feel the air every day. I don't know if that's going to be possible, but we know that's one of her goals and that's what helps her manage. And so her team will try to make that happen. Maybe they'll just open the window. I don't know. But it really helps to know that type of thing ahead of time. Spiritual, personal, cultural. We've talked about some of these already. Spiritual, different faith traditions have different traditions or rituals around end of life. Again, knowing about it ahead of time is going to help the healthcare team make sure that the right people are called, that the right things are done, and that the wrong things aren't done. Personal, like the woman who wanted her hair combed. Cultural, sometimes it's as simple as having the right language interpreters present so that we know about that. Sometimes it's about recognizing that an entire family needs to be involved in decision making, not just a single person. It's understanding that ahead of time to avoid confusion and questions in a time of emergency. So after you do all that, after you think about all this, after you talk with your loved ones, we really do want you to write it down. Now, our healthcare directive, I didn't bring you a copy today, but you can get them for free online on our website, and they're in 5 languages. We have English, Spanish, Hmong, Somali, and Russian. It really is valuable to write it down. And then once it's written down, it becomes a legal document once it's witnessed. And then doctors are bound to follow it. And if they don't follow it, they have to write in your medical record why they're not following it. There are a number of different directives. If you go online and you just type in a search engine, healthcare directive, you'll get a lot of options. And as long as they're legal in Minnesota, anything is fine. You could write it on a piece of notebook paper, on a napkin. It has to have your name, and it has to have the date. You have to sign it. It can't be an audio or a video. It has to be in writing. And then it has to be witnessed. In Minnesota, you have 2 options. One is to have a notary public sign it. So you can go to your bank, or most hospitals have them now. Or the other is to have 2 adults witness it. And all they're saying is, yes, I saw you sign it, I know your name is Julia, and I'm signing that you are who you say you are. Not every state has the same requirements. So if you have somebody maybe who gets their medical care here but lives in Wisconsin, they have to do a Wisconsin directive, and Wisconsin's laws are different than ours. North and South Dakota, the same as ours. Iowa, the same as ours, but Wisconsin is different. So, I don't know. They're trying to change it. And then the final piece of a legal healthcare directive is you either have to name your agent, pick the person who's going to be your spokesperson, or you have to give some medical instructions, such as, I do not want CPR, as an example. Or you can do both of those things. But you have to give some information in this document, not just your name and where you and what day you're doing this. And when we work with people, we say not only is it important to write it down, but it's important to write it down clearly. Because sometimes we'll see people who write down things like, I don't want to be a burden. Well, what does that mean? Pain in the butt. Again, does that mean if I need someone to help me walk to the bathroom, I don't want that? Or does that mean if I am laying in a bed and I cannot feed myself and I cannot take my own medications and I have, so you want people to be specific about what do they mean when they say be a burden. Maybe you have somebody who says I'm a burden if somebody has to drive me to the grocery store, but I can live completely independently, but I don't want to be a burden. So you need to ask people to define what they mean. Other people will say things like, I don't want any tubes. Does that mean a breathing tube? Does that mean an IV? Does that mean a feeding tube? What kind of tubes are they talking about? And maybe we need to talk about what is it that they're afraid of or that they think is going to be uncomfortable, or what is it they're really saying when they say I don't want tubes? Because there are a lot of tubes that could come into play in a medical situation, and you don't know if that's what they mean. Other people will say things like, you could try CPR. It's like, well, no, you really can't. You either get CPR or you don't get CPR. But what do they mean by try? Are they saying that maybe they would be willing to have a breathing machine for 2 weeks, 2 years? We don't know. So we really try to work with people to be very specific about what it is they're saying. And then, like I said earlier, it's really best if this is done way before somebody is in the hospital, because the stress of being in the hospital makes it that much more difficult. So I already talked about that. So the question came up of how often do you look at this and how often do you update it? We have something called the 5 Ds. The first one is whenever you start a new decade, or whenever you have a big birthday, like turning 50 or turning 65, or turning 18 once you become an adult. Because what you want when you're 25 is pretty different than what you might want when you're 70. And so you want to keep going back. And maybe you pick it up on your birthday and you read it over and you say, yep, that's good. Nothing's changed. Then you don't have to do anything. But maybe things have changed. The second D is death. Obviously not your own, but if there is a death that affects you, maybe the person you have chosen to be your agent has passed away. Or maybe it doesn't have to be a real person. Maybe you saw a movie and somebody died in the movie, and it was either a very, very positive experience, and you think, I hope that when it's my time, it happens like that. So I'm going to write more information on my directive. Or maybe it's the opposite. Maybe you see something or you hear about something in the news about a very, very bad situation, and you say, oh boy, I have to talk to my family to make sure that that does not happen to me. So it doesn't have to be a death of somebody you know. The third D is divorce, or really any relationship change. Maybe you get married. For me, I changed my healthcare directive when my son became an adult because I wanted him to be my agent. to be my spokesperson. When I made my first directive, he wasn't old enough. But when he was old enough, I changed mine because that relationship had changed. And then the last two Ds are diagnosis and decline. If you receive a diagnosis, that may change what your goals are and what kinds of treatment options you might want. Or if there's just a decline, maybe just from aging, but maybe you've been living with emphysema for a long time, but now it's getting worse. So again, things are going to change. So at a minimum, we would say every 5 to 10 years until you start getting older or until you have a diagnosis. And then you might want to revisit it every couple of years. A lot of the healthcare systems, if you are admitted to the hospital, it will be flagged that they will ask you if you've reviewed it lately. And they will ask people to look at it and make sure it's still accurate. So now I've given you a very quick introduction to what advanced care planning is, and we talked just a little bit about why it might be something that you would want to know more about. We have a special class coming up. We teach this class to healthcare workers and members of the community who want to be certified to sit down and talk with people one-on-one. So it's a certification process, and it's an 8-hour classroom day, plus there's some online computer work to do ahead of time. And part of what you learn in this class is to help people think about experiences they have had, because one thing we know is that almost everyone has some sort of a story. Their cousin or their grandmother or their neighbor. And you help people think about that and then say, well, how does that affect what you want? And that's part of what you learn in this class. Any other questions about the class or advanced care planning in general?
I think this was a really good event that you guys had. I really enjoyed it.